Have you seen it?
There we go.
Let's go.
And then share screen back in.
Okay.
Okay.
Thank
And all right. Sorry for the technical glitch. All right. So the learning objectives for this presentation is that at the end, we should be able to identify or classify bleeding as normal or abnormal. We should be able to try and identify the cause of the problem and be able to investigate and also be able to propose a management plan for the patient. So so what exactly is the right term to use? So before now, we use terms like dysfunctional uterine bleeding, menorrhagia, metrorrhagia, polymenorrhea, and all that, oligomenorrhea. But right now, for everyone to speak the same language, we do use abnormal uterine bleeding, and then you can now tell us what is the problem. So it will be AUB-heavy or AUB-prolonged bleeding, AUB-fibroid, so that everybody understands what exactly we're talking about, that this bleeding is abnormal and it's because the patient is bleeding very heavy or patient is bleeding for a long time, and it's just simple enough for everybody to understand. So we no longer use dysfunctional uterine bleeding, but abnormal uterine bleeding. So having said that, what exactly is abnormal uterine bleeding? So any bleeding that deviates from expected normal pattern is considered abnormal uterine bleeding. And that can be in terms of the duration of bleed, the volume of bleeding, the frequency of bleeding, or even how regular the menstrual cycle is. Any bleeding also outside of menopause is considered abnormal. Just those are the ways we classify or define abnormal uterine bleeding. So anything that is outside of normal. So that means we need to understand what normal is. So in terms of how many days should a woman bleed, 2 to 8 days of bleeding is considered normal. And bleeding every 24 to 38 days is considered normal in terms of how frequent. When it comes to volume, it's a little bit difficult to ascertain for sure, but academically, if you bleed anything less than 80 mils, then that's considered normal. For people who use Diva cup, it's probably easier to say, hey, this is how much is in my cup each time, and they can tell you in terms of volume. For other people using the pad or tampons, that volume will not help. So how exactly do we know that the volume is too much? We'll get to that in a minute. So this table gives us a general idea of what normal is and what the abnormal is on the other hand. So just like I said earlier, if we're thinking of how frequent or what is the cycle length of the patient. So 24 days to 38 days will be considered normal length. So if a patient does not have any bleeding at all when they should be bleeding, that's considered abnormal. If they bleed more frequently than 24 days, that's abnormal. And if they bleed after 38 days, it will be considered abnormal. And like we said, in terms of duration, 2 to 8 days. For regularity, each person's cycle is not the same every month. So people say, oh, my cycle is like a clock. No, it's not. Because the calendar months are not the same. So the dates cannot always be the same. So we expect a little bit of plus minus. So you can say my cycle is probably 28 to 32 days in terms of regularity. That will still be considered regular. But if we look at the cycles, and they're usually more than 7 to 9 days apart, then that will be considered, you know, a little bit off in terms of regularity. And then when it comes to volume, it's actually an individualized thing. If a patient says my bleeding is heavy, then it's heavy. If a patient says my bleeding is very light, it's light. And we'll come to a better way of even going through that clinically to try and ascertain what exactly patient means by heavy. Any bleeding in between the cycles. So for people, so we've ascertained the regularity, and then the bleed in between, that will be considered abnormal. If they bleed after sex, it will be considered abnormal. So anything that is off the normal is abnormal uterine bleeding, and we need to look into them. If they are on medication also and they bleed at abnormal periods of that cycle, we need to look at it and see what exactly is the problem, because sometimes they will bleed outside of the normal regularity, even when they are on contraceptives or hormones. Excuse me. All right. So how do we actually ascertain heavy? Like we said earlier, any bleeding that patient considers heavy is heavy because they are affected by these mentally, physically. They cannot do their usual social activities. And so if the bleeding is heavy enough that it affects their quality of life, then that is heavy, regardless of what volume it is. So in the clinical scenario, we try to find out really how heavy it is, how often they change their pad. So if they change their pad less than every 2 hours, that's considered, okay, that's a bit frequent. If they're passing clots, and they will tell you, oh, it's the size of my fist, or it just drops on the floor or in the toilet bowl, so that will be considered heavy, because clots just means the bleeding is so heavy, it's clotting. If they are having to change their bed sheets, or they are having to change their clothing because they get accidents, that's considered heavy. If they say, I'm just flooding, it's dripping down my legs. And if they become symptomatic and have anemia, so I'm passing out, I feel dizzy every time I have my cycle, those will be indicators to say, yes, this is really heavy. It's just a way to help us have an idea how heavy or what heavy means for that patient. But any volume really that patient considers heavy, we agree is heavy, and we have to help them out to make it better. So why do we really care about abnormal uterine bleeding? It does affect a large population of women, and the gynecology outpatient clinic, at least 10% of our cases are due to abnormal bleeding. The bleeding does affect, like we said, the quality of life of the female. There's a lot of loss of productivity, absenteeism from work, absenteeism from school. It can be quite expensive. You know, they have to, if you're changing your pad every hour compared to someone changing their pad every 6 hours, that's almost 6 times more you have to spend on sanitary towels. And also they have to be on medication. Sometimes, you know, they lose work, they don't get paid for that day. So it can be quite expensive for the female. And if they're bleeding all the time, it may also affect their marital life. They're bleeding 2 weeks out of the month. They cannot be intimate with their partner. It causes a lot of strife. So it does affect all aspects of life for the female. And if they become anemic, then that's also a problem. If they're in the reproductive age group and they're anemic even before they get pregnant, that can increase their maternal mortality, morbidity, even with the pregnancy. So it does have a lot of implications, so that we need to be able to help the female to have a better bleeding pattern. So how do we classify abnormal bleeding, or what are the causes? What are the causes of abnormal uterine bleeding? So The figure classification puts it into two groups, so structural related groups and non-structural. So we say it's the palm coin. So for the palm, we have things like polyps, we have fibroids, we have adenomyosis and malignancies. Those are things structurally that can cause abnormal bleeding. And then we go to the coin, which includes things like coagulopathies, ovulatory disorders, iatrogenic causes. And we also have the group that we call non-classified because they don't fall into any of these groups. But in general, this will be the two groups you'll be looking at when you're taking history from your patient to try and figure out if they belong in the palm or in the coin group. And also when we're doing our investigations, we kind of look at these two groups. Just to give us more insight into what could be causing ovulatory issues. So a lot of the endocrine related causes like hyperthyroidism, hyperprolactinemia, polycystic ovarian syndrome. Those will be things that will affect ovulation. And then for the clotting, we have things like von Willebrand disease, the hemophilia, platelet disorders. And we also have things like repeated cesarean sections with people having niches and bleeding from the scar defects. So how exactly do we arrive at the cause of the problem? We need to take a lot of good detailed history, and we need to have in mind that we don't necessarily always have one cause as the problem. A patient can have multiple causes leading to the abnormal bleeding, just to have that at the back of our mind. We need to examine our patients properly and also then move to investigations and imaging. But ultimately, we want to make sure we exclude malignancy as we find the cause and also make sure that our patient is well. So wellness in terms of, are they anemic? Are they stressed mentally with this? How do we help them? Things like that. So when it comes to taking the history, we want to know what their normal pattern is, and we want to know how we've how it's deviated from normal. So is it heavy? Do they bleed in between? Is it regular? Do they bleed after sex? If they are postmenopausal, we also want to know about that. So in reproductive age group, we always have to exclude pregnancy because people come with diverse history. So we always have to make sure we exclude pregnancy. We want to know if this is an acute problem or this has been going on for a long time. What drugs are they on? If they're on hormone therapy, we want to know how they use it, how compliant are they missing their pills? If they're on depot, for instance, when did they get their last shot? When are they due? So subtle things like that can cause abnormal bleeding patterns. And we want to know what else is associated with the bleeding abnormality. So do they have pain? Are they fatigued? Are they anemic? Are they passing out? That will help us to know how severe our bleeding problem is. And we always want to take history to rule out the risk for malignancies. So a quick examination of the patient will help us particularly to sometimes be able to focus your investigation, and sometimes it also rules out non-uterine causes of the bleeding. So if you look at the vulva, there are no ulceration, there are no masses, the vagina has nothing inside it, there are no growths that will point towards non-uterine causes of the bleeding. For postmenopausal patients, sometimes they could have bleeding post-coital from laceration or other things. So if we don't examine them, we don't necessarily know what the problem or where the problem is from, and they may not be from the uterus. And don't forget that the patient always have to be up to date with their pap smear. So that can be just a quick way of figuring out if they have any problem with their cervix. So how exactly do we investigate? So we talked about the different causes. So we've taken our history, we've examined the patient, and we are now ready to investigate. So how exactly do we do that? So everyone should have a CBC done so that we can know if they're anemic and they need to go on iron, for instance, for replacement, or some of them we need vitamin B12 as well as their iron. We want to make sure they are not pregnant. So beta-HCG is definitely a must in the reproductive age group. And pelvic ultrasound should be really for almost everybody who has abnormal bleeding. And for people with risk factors, we should screen them for sexually transmitted infections such as chlamydia, gonorrhea. And like I said, everybody should be up to date with their pap smear. So while you're examining, if they've not had a pap smear in the last 3 years, we should get one done. So outside of the first line, which is what really should be the bread and butter for most people in terms of what investigation is needed, we should be able to do other tests depending on what we get from our history. So if we have a lot of history that is suggesting the patient is in the COIN region, so we want to make sure we know what their TSH is, prolactin, we want to check their hormones if they're like polycystic ovarian syndrome from the history. We want to check the testosterone, the DHEAS, just to make our diagnosis and say, hey, this is what is the problem, and this is how we're going to help this patient. Endometrial sampling is very important, especially for people who have very irregular periods, over 40, they all need to be sampled. And if they are even younger and have risk factors for cancers that run in the family, they would need endometrial sampling as well. So taking our history about the risk factors for endometrial cancer particularly is very important, or for patients who have the Lynch gene. So endometrial sampling will be very important in that group of patients. So sometimes we have to do screening for bleeding problems, particularly in the younger age group. They do not all need to be screened for that, but you have to take your history to see what is their risk for having something like von Willebrand's disease, for instance. And we'll talk about that a little bit at the end. So if we do our ultrasound and it says suspicious for polyp, for instance, they're going to need saline infusion sonography to say, yes, they do have a polyp, and sometimes we can just send them straight to hysteroscopy where we can make the diagnosis as well as the management at the same time. For us in gynecology, pelvic ultrasound is really the mainstay of a lot of our investigation because the probe sees closest to the structure, and we can even now see so much that we don't need an MRI for a lot of cases. So for something like adenomyosis, for instance, I do, or most of us would not necessarily order an MRI because the ultrasounds can pretty much tell us if patient has adenomyosis. And so getting an extra MRI would not add anything to our management. But sometimes we still need that. For instance, if we have congenital anomaly of the uterus and the ultrasound it's not giving us a good idea of what exactly is the anomaly, sometimes we would order an MRI, but a 3D ultrasound well done, will also give you just about the same as an MRI. So MRI really goes at the bottom of our list in terms of what we use for investigation. So this is just to remind us for when an endometrial biopsy is indicated. So every postmenopausal woman that has any bleeding should have a biopsy. The only time you would not have one is if an ultrasound is already done and the endometrial lining is less than 5. that person then does not need a biopsy. But if it's more than 5, they definitely need a biopsy. If they are unable to get an ultrasound easily where you are, just biopsy them if they're postmenopausal, and then you'll be able to rule out hyperplasia or cancer of the endometrium. So 40 years is our cutoff. There are some places, I think in Europe, they use 45, but SOGC, it's 40 years. So patients with other risk factors that can increase something like hyperplasia. So people with polycystic ovarian syndrome, diabetes, obesity, not bleeding frequently, we need to do a biopsy. If patient is on unopposed estrogen for whatever reason, they need to be biopsied. If they failed medical treatment, we should biopsy them to make sure nothing else is going on. And like we said, if they have risk factors for genetic related issues, so the Lynch syndrome, Cowden syndrome, the risk of endometrial biopsy is up to about 60%. So endometrial biopsy should be done. If patients are on treatment for breast cancer or on tamoxifen for any other reason, they do need to have an endometrial biopsy done. And of course, if they have obvious estrogen producing tumors, probably from their ovaries, they need to have that done as well. So what does the endometrial biopsy involve? We don't necessarily need to do a DNC. An office pipelle properly done is as sensitive for us as a DNC. So doing a pipelle biopsy in your office is just good enough. And if you're really, really suspicious of cancer, when you take your biopsy on your form, you should put urgent or rush so that you can get your result back within usually 3 days to a week. You should get your result back if you're really very suspicious for cancer. That's just to help you get your result back fast and for the pathology department to prioritize your sample. All right, so we've taken our history, we've looked at the patient, we've done some tests, and we are here, and how do we help the patient? So in looking at the management approach, we have to consider what we found from our investigation. So what's the cost? Is this ongoing for many months, or is this an acute incident? What are the fertility plans for the patient? What are the patient's preferences in terms of the options that we have for management? What are the comorbidities or risk factors for this patient that will prevent them from taking one kind of treatment over the other? What's been their previous response if they've used some of this treatment in the past? And also we want to identify those who have other symptoms with the abnormal bleeding. So if they have cramps as well, you may not want to give them one treatment option over the other. And also we want to consider their need for contraception. So all this will help you know what is the best thing to offer your patient. So somebody who says, I'm done having babies, and is very low risk, you probably want to look at longer acting things in terms of medical management than things they have to take every day. Whereas someone who says, I'm planning to have a baby in 6 months, you don't want to put in an IUD that is good for 5 years. That person can probably do with oral contraceptive pill for the 6 months needed before they start trying. So those are the things we consider when we offer management to our patient. But what are the things that we hope to achieve? So we want to improve their quality of life. We want to prevent anemia, for instance. We want to make sure that they do have a regular pattern. I mean, when we say regular pattern, it also depends on the patient's preference. So someone might say, I really don't want to have 12 periods a year. I want to have 3 periods a year, or I want to have 4 periods a year. So for that person, if they're going to be on the pill, you can educate them on how it is non-cyclical, but they can use it as continuous so that they achieve what their aim is or what their expectation is in terms of their bleeding pattern, what is acceptable to them for a bleeding pattern. And we want to make sure in all of this, we prevent hyperplasia. So when it comes to management, our management could be medical or surgical. If we're going to go from least invasive to more invasive, we'll say we'll always start from medical and end up surgical. But ultimately, we have to consider our patient's preference. So there are some patients that would not be open to medical treatment and they just want to discuss surgical treatment. That is totally okay. Ultimately, it's their choice, it's their body. They have a right to decide where they want to go. But if you have a patient that is open to all your options, you probably want to go from medical. We'll probably want to start on medical things options first, which is least invasive, and then move our way to the surgical options if we're not getting anywhere. So if you have a patient who is regular in terms of the cycling and says, for instance, I have just one day that is heavy, you're going to offer the person something that can help with the one day. For instance, just taking drugs for one day of the month is probably more acceptable to that patient than being on the pill for 30 days of the month. So that person might just need to consider taking non-steroidals like your naproxen, Celebrex, and that will help reduce their bleeding by as much as 50%. That person might also be more open to using tranexamic acid for the one day, and then they move on to the next month. But if you have somebody who is bleeding for 5 days, and the 5 days are heavy, it's difficult to put that person on non-steroidals for 5 days every month. Some of them might be open to using the tranexamic acid for the 5 days because they do not want to use hormones. That will be acceptable. But usually if they're bleeding for long number of days, it's better to put them on hormone therapy. And if they also have periods that is all over the place, so they bleed a cycle that is 20 days this time, it's 40 days the next, putting them on tranexamic acid will not be the best thing for them because you want to make sure that you put them in a kind of a normal cycle. Like when we talked about what is our aim, we're aiming to give this person a cycle that is as normal as possible. So just putting them on tranexamic acid, for instance, would not help. That person is going to need something that is hormonal. And so when it comes to our hormone options, we prefer to put in an IUD because it's longer acting, it's doesn't need a lot of care by the patient, is good for 5 years. It does come with about 50 to 60% chances that they may not have any bleeding at all. It prevents them from having anemia. So if they're open to that, that will be my first option to the patient. And if they are not, we can put them on combined oral contraceptive pill, or we can put them on Depo-Provera shot. So essentially our medical options will be using something as simple as non-steroidals, putting them on tranexamic acid, or putting them on the hormone therapy, which could be your Mirena, Tylena, which are progesterone-based IUDs, not copper. We can have our Depo-Provera, and we can have our oral contraceptive pill. There are some people that will prefer to do cyclical progesterones only. We do not find them as helpful as the combined or the longer acting progesterones. But if that is what your patient is open to, definitely it's better than doing nothing. We also have to always think about replacing their iron. And so putting them on oral iron is always something to consider. And if they're really anemic, we should consider giving them intravenous iron. We do also use other medications which are not our first stream, and it also depends on what other things we found in our diagnosis. So we can use the GnRH agonist, like Lupron injections. We can use danazol as well. So those are all medical options that are available for us. And like I said, it all depends on your findings as well. So for someone who has fibroids, for instance, I will be more inclined to going either with the Mirena IUD or with my GnRH agonist if they're having a lot of bleeding, because we know the progesterones will slow down the growth of the fibroids, and the GnRH is likely to put them in a kind of menopausal state where they would be amenorrheic, and therefore they can take control of the heavy bleeding that comes with fibroids. What other options can we give to the patient? So we do have surgical options, and everything is not about hysterectomy. Endometrial ablation works quite well. In Regina, for instance, most of the time we can get patients in for an ablation within 2 to 3 months, whereas hysterectomy will probably take about 15 to 18 months. So that's always a good selling point for the patient, and say, hey, this is an outpatient procedure for most people who do not have any risk that prevents them from having this done as an outpatient. It takes probably like 3 hours of their day and they're gone, and it does work quite well. It reduces the bleeding that is heavy by as much as 80 to 90%, and about 50% of the patients will be amenorrheic when they have an ablation. So it works quite well for a lot of people with very heavy bleeding. They can get in easily to get it done, and life moves on. Hysterectomy definitely is an option. For the patient, it comes with more risk in terms of surgery, and it also comes with taking time off work. I get a lot of people say, I'm done having kids, so just take everything out. That is not an indication for hysterectomy, but they have to have a reason why we have to do that. So in addition to the medical treatments, for instance, or while we're waiting for our surgical options, uterine anti-embolization is something we consider to help reduce the bleeding, and also it helps for patients with fibroids. So it helps their bleeding. But I have to say that it is meant for people who are not considering having kids, because we're going to be blocking the uterine artery vessels with some pebbles. But having said that, though, we've had patients who've gone on to be pregnant after uterine artery embolization, and a lot of them have had successful pregnancies, but it is not our preference for people who are still open to have children. Of course, if from your investigation somebody has polyps in the endometrium, we want to recommend polypectomy. And if they have fibroids, we can have myomectomy done. We can also have hysterectomy done, depending on their preference and their reproductive expectations. So surgical management will depend on what you find, what is the patient's reproductive plans, and what is their acceptable management expectations. All right, so that's general outlook when we're looking at how to care for these patients with abnormal bleeding. So sometimes the patient will come in an acute state, or with profuse bleeding, or they're brought in, they're collapsing, and that will be considered acute. So bleeding that is profuse, prolonged, taking forever to stop, they do warrant urgent intervention, and a lot of these patients will present to the emergency department. And so when they do come in, we want to make sure that the patients are stabilized, so the ABCD, and we want to order urgent labs. We want to know what their hemoglobin is, what their blood type is. Particularly, we want to make sure that they are not pregnant. And we want to do a quick examination Like we said before, you're going to check the belly, you're going to check the vagina, and you're going to have your imaging done. But while we're doing all that investigation, we want to make sure that we promptly stop or reduce the bleeding, and we want to make sure that we replace blood if they're really very anemic, or we want to give them IV iron if they are stable but anemic, right? So what do we use? In the emergent scenario, we do use oral, we can do IV estrogen in high doses. We can also do high dose progestins. And sometimes we can do just oral management with combined birth control pills, but in high doses. Such patients will also need probably IV tranexamic acid, and sometimes they may need urgent endometrial ablation or even uterine artery embolization if we have interventional radiology departments. They are usually happy to do that on a quick basis for us. So if somebody is bleeding profusely, we may need to send them to Emerge, or if they present in Emerge, we have to help them stop the bleeding urgently by using high-dose hormones. And while we're doing that, we also want to make sure that we rule out for malignancies. So if you have a patient that is bleeding that bad, you may want to consult gynecology to help with the scenario. So this table just shows us some of the things we can use for the acute management if we're in that state. So IV estrogen, it's at the dose of 25 milligrams, and we can give it every 4 to 6 hours. So while the patient is there in Emerge, we give that to them. Sometimes they will need to be admitted if they need more workup. But a lot of times they can just get this through the emergency department and then go back home on oral contraceptive, or they can go back home on Depo-Provera, or they can go back home with an IUD prescription to see the gynae in the next couple of days to have that inserted. But the IV estrogen will help stop the bleeding at least and make things manageable for the patient. We can also put them on combined oral contraceptive pills. So if you use, we usually will use the monophasic oral contraceptive pill. That means the one that has just one color. And so it has the same dose. So something like your Alice, Mavelon. And if you give the patient, I usually will do 3, 2, 1. So I do 1 tablet 3 times a day for 3 days. I do 1 tablet twice a day for 2 days, and then I put them on 1 for the next month. And so it will help reduce the bleeding significantly or even stop the bleeding early. And then they can continue for the 1 month and then have their bleeding at the end of about 5 weeks. And that way they get a little bit of break, and then you can further do your test while they're waiting and then have a bit more definitive plan. But that helps you to reduce your bleeding significantly within a short time if you use the high dose combined oral contraceptive pill. So if you have somebody who presents to the office and says, my bleeding is not stopping and we've ruled out malignancy, or they have very low risk for malignancy, that will be something to consider for that person, even in the office. And then you can follow up with them as they go on. We can also use the Provera high dose, 20 milligrams oral daily. So we can do 3 times a day of that for the next 1 week. And we should know that once the patient stops the Provera, for instance, they're going to have bleeding within 1 week. So that's why, for me, that's not my preferred thing. Or you can use it as just as the interim, stop the bleeding, and then put them on your combined oral contraceptive pill after that, or you can put them on your Depo after that. But to stop the bleeding within a short time, that will be something to use. Provera 20 milligrams 3 times a day for about a week, and their bleeding should significantly stop or reduce. And we can add any of these with tranexamic acid. So when it comes to tranexamic acid, it's not going to help for bleeding that is just prolonged for many days. It is more ideal for bleeding that is within 2-3 days, but heavy and it helps with your heavy. It doesn't necessarily give regularity to the cycle, and so it will not be the only thing you will give to someone whose cycle is not regular, for instance. It will be an adjunct to what other hormonal therapy you're given. Just to talk about this special group of people, the younger girls. We do have a lot of girls starting periods earlier now than before. So it's not unusual to see a 9-year-old, 10-year-old having their period. And so they can present with periods that are irregular or periods that are quite heavy. So within the first 2 years of menarche, or when they get their first period, there is usually maturity of the hypothalamus pituitary ovarian axis. And so periods might not be ideal. So once you've taken history and everything else is fine, these young girls will definitely benefit from going on oral contraceptive pill so that life can be manageable and they don't have to miss a lot of school. About 20% of them will be from having clotting disorders. So the other 80% will not be related to clotting disorders. So we don't necessarily have to do clotting screening for all the young girls. But about 20%, so when taking our history, we should go all out to find out what are the risks for clotting disorders. And if they screen positive, then we should be looking at that. We should also consider extrinsic hormones. So some of them have started hormone therapy, but they cannot be compliant because they don't consider it very important. So this is where we look at other options for them. So if they're on the pill, you may want to talk to them about using longer acting things like Depo-Provera, which is low maintenance and it helps them with forgetting to take their pills. PCOS is something also that is important in the younger people. Infection, especially if they're sexually active and have multiple partners, that will be something to be to have at the back of our mind. We also should not forget having abnormal uterine anatomy and also having tumors in this younger age group. Just to bring those little things to our mind, that when we're dealing with this younger population, we should particularly be thinking of these things. All right, so for screening them about bleeding disorders, this is a little table that gives our screening. So if they've had heavy bleeding from the first cycle, that will be a risk factor to say they might have something like von Willebrand's or some bleeding disorders. So if they have that from the first day, that will be a red flag. If they have bleeding anytime they have dental work, or if they have surgical related bleeding, that will be a risk factor. But if they have two of the third area, so if they have two of epistasis or bleeding while they brush their teeth, or bleeding gums, or family history of bleeding disorders, then that will be an indication that they need to be screened for von Willebrand's disease. But if we need help, we can always refer to our hematology colleagues to help us figure out what bleeding disorders they might have. So when do we refer? I think we can refer anytime a physician feels like, you know what, this is out of my scope. We should feel free to refer and say, hey, you should go see someone who deals more with this problem. But you know what, the reason we're doing this today is also so that we can get comfortable and also be able to start our patients with simple things while they're waiting to see the specialist, because sometimes the wait list can be long. And so if we can start them on oral contraceptive pill, we can start that while they're waiting, or we can start them on Depo-Provera while they're waiting. So anyone with very heavy bleeding, anyone who is not responding to medical treatment, anyone with severe anemia, anyone with suspicion for cancer or someone we think might need surgery, we should refer immediately to the gynae colleagues. And if we think this patient needs to be sampled or needs IUD, we've counseled them, and we don't do that as part of our scope. We can send them to our gynae colleague. But like I said, if you're not comfortable with managing the patient or it's outside of what you consider your comfortable scope, you should refer the patient to the gynecologist. And if we think they have cancer, rather than sending to gynae, we can just send off to gynae oncology directly. It kind of gains us some week. Sometimes we may have to get the input of the fertility specialist if patients have conditions that probably warrant surgery sometimes and also might affect their fertility. Sometimes we do refer them to the fertility specialist to get their input on if they think it's the right time to do the surgery, what kind of surgery should be done, how extensive should it be, how minimum should it be. And also, we should not forget our hematology colleagues. They can be of good help, especially when we have bleeding disorders. I think that's what I have today. It's a really broad topic, and I just wanted to make it as simple as possible. And these are my references. I thank you for listening.
Thank you, Dr. Adetola. We really appreciate your time to prepare this topic. And this is the second time we are coming back to present this. And anytime we listen to it, I always say, wow, I've gained a lot today, and I know a lot of people have questions. And this is the time for us to ask you questions. We can start. Anybody with questions, please feel free to talk. You can unmute yourself. And also we prefer people to try to raise their hands, and I will call you. Thank you. Any questions so far? Few things that I put down in my jotter is as a family doctor or as a GP, anyone with abnormal uterine bleeding over 40 years or maybe from 40 years and above, we should try to refer for biopsy. I think I'm right, Dr.
They need
Adetola?
a biopsy.
Okay.
I mean, if you can do a biopsy in your office, you don't need to refer for that. But if you do not do biopsies, they do need a biopsy.
Thank
when
you.
they're over 40.
Yeah, and I read something that sometimes around that age, that maybe pelvic ultrasound lining is not really useful. Yeah. Is there any comment about?
So when they
lining?
when we look at lining really is more important for the postmenopausal age group. So where you say, because in the postmenopausal age group, it's not like you have any phase. There's no follicular or luteal phase. So that is that person's lining, regardless of when you do the ultrasound, right? And so we do know that if you're more than 5, with some other risk factors, we won't go into what is it 5, is it 8? That's a different topic. But generally, if it's over 5 and they have abnormal bleeding and they're postmenopausal, we will do a biopsy. But if they're non-menopausal in the reproductive age group, we do know that the lining is not the same in the follicular and luteal phase. But what is considered thick generally will be anything over 16 millimeters. But regardless of the thickness, really, if you're over 40, you're going to get an endometrial biopsy. So the lining really doesn't come into how we make our decisions for the reproductive age group. We just use the age. Whereas in the postmenopausal age group, the lining will come into how you make your decisions.
Okay, thank you, Dr. Adetola. When we talk about the risk factors, if somebody is 30 years of age and the BMI is about 40, having abdominal uterine bleeding, is that person a candidate for biopsy because of the obesity, or we should focus more on the family history?
So at 30, well, if you look at our community, a lot of women have BMI of 40. So if we're going to biopsy all BMI of 40, that's going to be a lot of people. But if you look at, so she's 30, if she's amenorrheic, for instance, maybe she gets 2 periods a year, that is a long time of having unopposed estrogen, because that's probably anovulatory. So if you look at that and then combine it to the BMI, that or other things like this patient is also diabetic or have metabolic syndrome, that will be a necessary indication for endometrial biopsy. But if she's fine, she's active, she's 30 years old, she has 10 periods a year, I would not necessarily biopsy her with a BMI of 40. So you have to look at the whole patient and what else is the risk factor.
Okay, thank you, Dr. Adetola. The last question that I have is, having someone with abdominal uterine bleeding and the pap smear is about 2 years ago, do we still need to consider the guideline? Do we try to go ahead to do pap, or we should still wait for that 3 years to be complete? What's your comment?
All right. So if a patient is getting their pap smears regularly, so they get it every 3 years and it's always been normal. If they have abnormal uterine bleeding and they've had a pap smear 2 years ago, I will not necessarily do a pap. We'll follow the guideline because risk of having cancer of the cervix is on the low side because this person is compliant with their screening. But if it's someone who's never had a pap smear or who's just had one pap smear and there was some abnormality and we didn't follow up, I will do. So let's say it says low grade abnormal or ASCOS even, and in the last 2 years, they haven't done another one, I will do one. But generally, we tend to stick with the guideline, except there's other factors. So if somebody has had LEAP, for instance, for high-grade lesion, they should be doing yearly pap smear. So if that person has not done one in 2 years, then I will do. So we have to follow the guidelines in managing the abnormal paps, but just having abnormal uterine bleeding will not make them need pap smear more frequently, except we see a lesion on their cervix when you examine it.
Thank you, Dr. Adetola. I know we're going to bring you back on this topic of pap and cervical cancer. We'll look towards next year to see when we have time. We have a comment in the chat box, and I think I have one hand up, but I'm going to read the comment from Dr. Yinka Kindeko. Many thanks, Dr. Adetola. Apologies, I was late. You're welcome. Sorry if you've talked about this already. Are you able to speak about risk factors like hormone disruptors, especially the rumors of relaxers, hair product being a trigger for Black women?
Well, I guess, so what cancer are we talking about? That's kind of a generic thing when it comes to cancer and the use of things. So that's probably not my strong point or my area in terms of what is in the relaxer and what is being absorbed. And we're looking at now talking about environmental factors that increase the risk of cancer. I think that will be a topic for another day, really, not in terms of abnormal uterine bleeding.
Okay. Thank you, Dr. Adetola. And my comment about that is, We have a lot of risk factors where we come when we talk about environmental factors, as you mentioned, even occupational health. And when we talk about relaxers, we need to start to analyze the content. We have exposure to benzene and a lot of things, but as you said, it's a big topic for another day. Hope we'll find time to discuss that also. Thank you. Dr. Ukpabi, it's your time.
Hi, good morning or good afternoon. Thank you, Dr. Adetola. Just a quick one, going back to the women who are above 40 and needing biopsy. So say this woman is still having regular periods, just like an increase in, her periods are still like regular, but they've gotten heavier, say maybe in the last 12 months. So you've done your basic investigations, you've gotten a scan, and the scan says she has multiple uterine fibroids. So maybe like really small fibroids, but there are a lot. You kind of know the cause of this bleeding. Will you still go ahead to biopsy her?
I will still biopsy her because, like we said earlier, you can have more than one cause of the abnormal bleeding. So if you see the obvious, sometimes the obvious is not just the problem. We want to make sure that we've done our due diligence, especially if you're going to say, okay, she has a lot of small fibroids, so we're probably going to manage conservatively. We're going to put in depot preferably, or if she's open to uterine artery embolization, we're going to embolize her, and then we're going to not do something for a long time. You want to make sure that this patient is actually healthy and doesn't have any abnormal cells or cancer that you need to. So sometimes it's not just because, so if they have hyperplasia, for instance, you need to manage them in a certain way before you leave them alone. So if you did not know this patient had hyperplasia, you probably will not do a repeat biopsy and just say, oh, she has fibroids, it's fine. Whereas things can get worse. So you still have to biopsy them, even though you can see some obvious things, you still have to look for the non-obvious.
Thank you.
Thank you, Dr. Adetola. Dr. Joe.
Good morning, everyone, and thank you so much, ma'am, for that extensive and knowledgeable delivery. My question is about women of reproductive age with infertility, but also presenting with abnormal uterine bleeding. Most of the time when the cause of such has been found because of the problem of infertility, they do not want to do hormones, they do not want to do blockers, they do not want to do surgery. What advice do you have for such women? Thank you.
All right. So for such group of women, and I do see a lot of this group, it's really difficult to navigate. So sometimes you may want to pass the bulk and say, well, go see the gynecologist and think about your options. So first we want to know, okay, they have infertility. Are they actively going through management, or are they planning to have a kid 5 years from now? Are they presently trying? So it depends on where they are. And so if we know where they are, we can reason with them and say, hey, you know what, if you're still going to try in 5 years, we still need to have you be healthy over the next 5 years. And we do know that the hormones you're going to be on is not going to affect your fertility. It's probably going to be a good thing because you're not ovulating anyway, and you're keeping your eggs until you're ready. So we can talk to them that way. However, there are those that would really not want anything. So what you can do is make sure that you can reduce their bleeding as much as you can. So they might be open to taking tranexamic acid, or they can take the non-steroidal antihypertensive. And also, we can make sure that we keep our eye on their iron and hemoglobin so that they remain healthy. But if they're not open to hormone at all, we are just left with tranexamic acid, taking NSAIDs, and making sure that they remain healthy. I hope that helps.
Thank you. Yeah, thank you very much.
Thank you, Dr. Adetola. Dr. Mojid Edifemi. Dr. Mojid.
Moses, are you able to mute?
Dr. Adetola can do that. I'm trying to meet Dr. Oluwole. Dr. Oluwole, can you please mute on your side? Dr. Oluwole. Yeah.
I'm trying to see where it.
Just after Dr. Mojid. Send him a message.
It becomes a permanent solution. And that is why they
just send him a message. I'm not sure if he's seen it, and he's not be calling his name.
Because some people anything that is going to stress me up, I will let them know.
Moses, the host can actually mute
mute
the person.
That's
Just
what I'm
click
trying
on
to
the person and mute it. They're
Can you
probably
mute
not
everyone,
available.
Dr. Let me try. Mute everybody. Okay, good. Thank you. Try to.
I think
Hello,
somebody's hands was up.
Can you hear me now,
sorry.
Dr. Mojid?
Yes, I can. I was having issues with my mic. Sorry for that.
That's good. That's good. I think we're good now. Thank you.
So I guess, thank you very much for that very wonderful presentation. I guess my question is almost related to the earlier question that was just asked. So for preteens with anovulatory cycles, how do you navigate situation where you know, okay, this child needs hormones, but for some reason the parents don't want this kid don't want this child to go on hormones? I've had a few situations like that. They don't want the kid on hormones for some reason, but you know this is anovulatory cycles. How do you navigate that? You've tried maybe tranexamic, you've tried NSAIDs. So how do you navigate that? That's the first question. Then my second question is, how long can you attribute a bleeding to anovulatory cycles after menarche? Is, say, 4 or 5 years after menarche still likely to be anovulatory, or is there like a cutoff? Then we need to think about something else at this point. Thanks. Those are my questions.
Okay. So after menarche, usually 18 to 24 months is what we give for the HPO axis immaturity. And after that, we expect that things should have kind of settled. And so if they're still not settling after 2 years, then we have to look at other factors. That's in terms of how many months or how many years do we give them. So pretty much like 2 years. So for kids whose parents, and like you said, there are a lot of parents who do not want their kids to go on hormones. So sometimes I kind of try to sidetrack the parents. So it's what I do sometimes, because they are both there and the kid is there, and I'm talking directly to the kid and asking how school is, and how they feel about school. And the parents are listening to how sad this young girl feels about the fact that she cannot do gym, she cannot go for swimming, she cannot go for school. School is sucks for 1 week, you know. So we kind of go and try to let the mom realize that this is not just we're talking about bleeding. This actually affects your daughter's life. And we try to have that discussion with the daughter so that the mom can actually see how it's affecting the girl's quality of life. And a lot of moms will be swayed by that because I say, you know what, because your daughter is a girl does not mean she should miss school 2 days of every month. The boys are not missing school, so she should not be missing school. There are a lot of things that can be used. What is your fear? Are you thinking she might become sexually active? You know, I actually bring out what their thoughts are and try to help them navigate through it. Because for a lot of parents, they feel if my child starts the birth control pill, she's going to become promiscuous, she's going to do this and that. And we actually talk about what their concerns are. And so a lot of parents' mind will be changed after that if you are able to navigate what their concerns are. Having said that, there will still be very few people who will say no, and unfortunately, there's nothing you can do. So for such girls, we're just going to say, well, take your naproxen, make sure you take it with food, take extra iron, take tranexamic acid if they're open to that. And that's all you can do. But a lot of times, if you really take time to talk to the girl and let the parents realize how their quality of life is affected, how they miss a lot of things, and address what the parents' concerns about not wanting the pill is, then a lot of them will change their mind and actually work with you. And so for those people also, I always emphasize that we're going to put their kids on very low dose medication to start with. And all that tends to help them change their mind sometimes, but there are few people that you cannot help them. They would refuse. So there's nothing you can do in such scenarios.
Thank you, Dr. Adetola. Do we still have any questions? I think we are a few minutes over time. Thank you. We've come to the end of the CME today. Sorry for the little glitch. And we ensure that everybody is muted when we are coming in next time. And I want to say thank you to you again, Dr. Bunmi Adetola, for all you do for CANPAD. We gain a lot from you, and we'll keep on coming back to you because we're still going to go more into gynecological malignancies, and we have a team of gynecologists. We're going to talk to you, your team. Thank you very much. And if there's no question, we're going to adjourn till next week. I'm just trying to look at the chat to make sure that I'm not missing any question. Thank you. We'll see you next month, same time, second Saturday of every month. Thank you very much. Enjoy your weekend.
Thanks for having me.
Thank you.
Bye.